the RSI process. I feel like the screen is very dark. I'm gonna make it.
Oh, yeah, I got you.
I'm gonna make it more visible. There we go. Okay, cool. So we'll start by talking about the fact that everything is a choice, and what I mean by everything is a choice is certainly not that like. I guess we could just not manage the airway. That's not what I'm talking about. But like the process of choosing RSI is a choice. It's always going to be a choice, and we need to approach that choice judiciously. That's how RSI became so controversial within EMS, is that people made some bad choices. Now, we certainly are capable of making that choice, so we just need to make them judiciously, pick the right person, not insist upon things that aren't working, and that kind of thing. So, this go around, we are talking about the actual process itself. So, did anyone in school ever learn about the 7 Ps? No. Okay, cool. So these are a little old, so old that if you're looking out there and you're thinking like pre-treatment, God, I haven't heard or done that in like 20 some years. Yeah, that's true. So we're gonna change pre-treatment into the pre-procedural timeout. So we will go through all of these steps and what it means to do that, the preparation, the pre-oxygenation, that pre-procedure timeout, the paralysis with induction, positioning, placement with proof, and then the post-intubation management. So let's dive right in. So preparation. And this one is, honestly, the prep has a lot to do with it. A lot to do with the success of these. I'm sure you guys have seen intubations where like all of a sudden you're scrambling for something in the middle of it and like everything goes. It takes one little thing missing for everything to just fall apart. And this is probably more so for RSI because the timeline is so delineated. So for the prep, we do have to have a plan with the whole team. That includes our medications with dosage, what equipment we're gonna use as a primary and as like a backup. Have the 2 to 4 backup plans just in case things are going sideways. Knowing the roles will be defined a lot by what we talked about today. And we'll almost have like a pit crew kind of approach to it, to where everyone should be able to fall into this pretty seamlessly. And there shouldn't have to be a lot of discussion about roles because everyone knows what their role is. And then just to make sure that everyone actually knows the plan. So one of the things that we need to get together, and this will be particularly important for the EMT in the process, is to have all the equipment. So what kind of equipment do we need for an intubation? I got an acronym for you. You don't have to use mine. This is the one I use. It's called Blessed Backup. The only thing is it has 3 S's. You just gotta remember it has 3 S's. So what kind of equipment might you want for an intubation?
A BBM too.
Cool, I like BBM. Laryngoscope.
ET2.
Okay.
Suction.
Suction. And then
Stylet.
okay. Stylet.
See ya, Kyle.
Oh, this has been great.
Glad you learned something.
Can we take those?
Yeah.
We're on the 3rd S. We got suction and stylet. Syringe, I love it. High five. Okay. Another E. Ooh, I like it. G is a little tricky. Drugs. It's probably not the first word that comes to your mind when you're thinking about medication, but yeah, drugs. And then backup is what it is. You gotta have at least 1 or 2 backup methods that can get you out of a jam. So you guys did that very well. I'm very impressed.
Medications.
To what?
You change the details of medication.
How southern.
That's our LaBelle girl.
They're gonna need blessed after that.
I like that actually. Okay, so now let's talk about roles. So we will need at least 3 people all to proceed with the RSI process itself. And if you're thinking to yourself, well, what if we just send a rescue? That's okay, we'll address that in the timeline, I promise we'll get there. So, what might you imagine that the top person at the head of the bed is going to do?
Airway.
They're the airway person. Cool. So this is gonna be it has to be a paramedic role, this is gonna be the airway leader. This is the person who's gonna direct through the process, through the 7 Ps. Talk about like when each next step is happening, and they're the ones who are actually gonna get the ET tube in place. What do you guys think these other two roles might be? You know, curiously, I don't have that specifically on here, but I like where your head's at, very important.
They're assisting with everything. So,
Okay, they definitely are assisting.
meds.
Okay. And honestly, you're nailing it. So one of the people who's gotta be a paramedic is gonna be like the medication manager. This is the person who's going to have meds ready to go, they're gonna be the ones administering them, and then quite frankly, after the meds go in, you're kinda just standing there, but kinda just standing there becomes watching the monitor. Let's just acknowledge the process that this is. We've all seen an intubation where the intubator gets total tunnel vision, looking down the larynx, and gets totally oblivious to everything else going on. We're building that into the process. That is almost by design. We know that that's gonna happen to that airway person. Not every time, but sometimes. And so the other two roles we'll have as part of it, in that like, you gotta watch out for that person, you gotta watch for that person, you gotta watch that person's back. So this person will not only give the medications, but then they'll move into that backup spot about, hey, potentially if that person doesn't get the airway, they can switch into that role. And then also that patient safety role of like, hey, we gotta back out, like their sats are dropping, this isn't safe anymore, let's bag them up, let's try it again, later by a different method, etc. And then the EMT role, they're getting all of the equipment ready, and they're also playing patient safety role. Every single person in the whole triangle, if you will, plays a patient safety role, but particularly those who aren't doing the intubation are gonna keep a close eye on that. So, we put it all together, I'm a pretty visual person, and so if we broke that down by equipment, person at the head of the bed gets a laryngoscope and, quite frankly, nothing else. Everything else gets handed to them as it's needed, but they in that moment, they don't need anything else, not even a tube. The EMT role has really everything else. So the EMT plays a huge role in the progression through the process, in that they really have to anticipate what the next step is, what's gonna be needed next. So as Blade goes into the mouth, that EMT has the tube ready to go with the stylet and the syringe all hooked up. It gets handed over when asked for. And once the tube goes in, they're removing the stylet, they are hooking up the end tidal. So it's very much about the sequence of events and knowing what comes next. And the EMT will actually control a lot of that flow through the process and to make it really smooth. So that's fantastic. And then the other paramedic will be the one who's in charge of the medications. And while everyone's got a role in watching the monitor, that's primarily gonna be that second medic. Yeah, okay, we'll leave that. Remind me to come back to the 3-person triangle with just a rescue coming on scene, but we'll come back to it. Okay, cool. So that's our preparation. We all know our roles. We have a plan. We got all of our equipment lined up, and we have the paramedic will decide what medications we're going to use for that patient in that situation, assuming we have a choice. The next step is pre-oxygenation. So now we got pre-oxygenation in 2 phases. We got one strategy for before the intubation itself, and one strategy for during the intubation. So before, we're gonna go hard or harder, and there's no other options. And so this is going to be 100% oxygen going full blast, 15 liters down a breather, or a CPAP, or a BVM if need be, but with a nasal cannula underneath it, also going at a pretty good pace. You guys have seen this before with cardiac arrest. The whole idea is to be prepared for the apneic oxygenation that happens during the procedure. So this, admittedly, hyperoxia is a bad thing, but we are doing this for a very short period of time, and we're doing this to stack the deck in our favor. We are going to, in just a little bit, purposely make this person stop breathing. And so we've got to build ourselves in a few minutes of time where it's okay that they're not breathing. And so we gotta get them pre-oxygenated, we gotta get their oxygen levels up, we've gotta wash out that CO2 so that we can have what they've debated is called the safe apnea period, where you can truly be without breathing for a period of time and it's okay. So then when we actually switch over into doing the intubation, we'll just remove that additional oxygen and just leave that nasal cannula going on. That way you don't have to switch them out, you're just removing the top one. Now, admittedly, that apneic oxygenation will create this column of air that's still feeding down into the lungs, that's still potentially being able to do oxygen exchange. With the caveat that 95% of the time that we do a tube, it's not gonna do anything for us. This will be pointless for us most of the time. Because that patient who starts an intubation, starts the RSI with a SAT of 98, and then they'll naturally desat a little bit, but then we successfully get the tube, we've prepared for this adequately, and then we get the tube in by the time that they're 94%. Yeah, apneic oxygenation didn't do a thing for that person. Where apneic oxygenation is going to like save you is on the person who's like just barely by the skin of their teeth, they're starting to drop their stats, and we get the tube just in the nick of time. It's gonna give us just a few more seconds to allow that to happen before they desaturate. Cool. And then once the tube's in and all that, we can take it off. It's not doing anything after that. But, so all of this is about talking about the amount of time that we have to actually get the tube in, the safe apnea time. So, chances are somebody saw this in paramedic school and it still gives them nightmares. But this is the amount of time that it takes for your body to desaturate over a period of time. So if you see that bottom axis, it's talking about time in minutes. And if you see the side, it's looking at pulse ox. Kind of. It's SaO2, not SpO2, but close enough. But you'll notice, notice this normal, healthy adult. When we truly pre-oxygenate the normal, healthy adult, and I'm gonna count most of us in here as normal, healthy adults. Well, no offense to anyone, myself included, that this also includes somebody of normal weight. So we're talking about a normal, healthy adult with normal weight. When we pre-oxygenate them adequately, if you watch, this sac goes from about 99, and out here, it's only crossing 95 at the 7.5 minute mark. It's a long time. Now, admittedly, this isn't our patient. Even when we have a patient who is a normal, healthy adult of normal weight, we are not catching them on a normal, healthy moment. This would be like your MVC, who like 2 seconds ago they were normal, healthy, and now they're no longer normal, healthy. Chances are most of our patients are gonna be at least in this moderately ill category, if not more severely ill. Realistically, we're not doing tubes for people that are doing great. This normal, healthy adult of normal weight is really more for elective surgeries, and we're not doing that. This is not us. So we have far less time. You can see that the other lines are much shorter until we start going off the curve and desaturating. So if we take a look at this moderately ill adult, you may not be able to get them up to 95. And you guys have seen this. This is a person that you have the oxygen like turned on full tilt and like, they're just never crossing 94. Okay? This is that person. You get them up to a solid 94. And even then, with good pre-oxygenation, they're crossing the 90 percentile mark in about 5 minutes. Like, nothing to like shake a stick at. That's still pretty good. But like this goes back to this pre-oxygenation, this adequate preparation. We're talking that all the things that we do on the front end are gaining us seconds. And those seconds are precious when we actually go to do the intubation. Every additional 30 seconds makes a huge difference in our likelihood of getting the tube the first time. Children will fall off the cliff faster, just by the nature of things. And you guys have seen this too. So think about the patient who you guys see them, when you guys first see them, their stats are just absolute, complete garbage. Something in the 40s, 50s, 60s. You guys get them on non-rebreather, CPAP, something of the sort. And by the time, after a few minutes, you get them up to like a good 90s, good solid 95. But you go to hand them over in the hospital, and the hospital takes whatever oxygenation that was off of them, and by the time they're back on the hospital monitor, they're sat in the 70s. Just be aware that the less healthy somebody's lungs are, the quicker they're gonna fall off that cliff, and so the more we wanna stack the deck in our favor. Cool? Okay. So now we have gotten all of our equipment out, it is all ready to go. We have pre-oxygenated the patient, and keep in mind that this can happen simultaneously. It doesn't have to be like, I've laid out my equipment, then I'm throwing oxygen on. At the very least, we're showing up with a rescue, right? So we're showing up with at least 2 people. One person can work on getting the patient on the oxygen, one person can start working on laying the equipment out, but now it's time to actually go for it. Now once we give meds, there is no turning around. Once we give meds, we have taken away that patient's ability to breathe, and the airway is now 100% on us. We're on the hook. So, we're gonna do a bit of a procedure timeout. It takes 30 seconds into that. It doesn't really take even that long. Basically what that means is that every single person involved in the intubation has the ability to say, yeah, this something's not safe, we're not ready, let's delay by a little bit. Everyone has the ability to give us the go or the no-go. And unless everybody's on the hey, let's go for it route, it's just not happening. And this may be something as simple as hey, I don't have all my equipment, I'm still looking for the end title. We gotta have all this stuff before we go. So everyone gives it essentially a thumbs up for the pre-procedure timeout. And that not only goes for all of the members of the team, we gotta do this for the patient too. I'm not asking you to ask the patient hey sir, are you ready to go? I mean, if they're conscious and able to participate, then sure, feel free to ask them, but what we really mean is the patient stable enough to tolerate what we're about to do to them? And so let's do a couple of examples for this. So, the following little cases that we're gonna do are patients that are calls for difficulty breathing or chest pain or something of the that have all undergone those first 2 steps, so that we have done our prep, we have done our pre-oxygenation, every member of the team is going, yeah, let's do this, it sounds like a good idea. Now we're trying to determine if the patient is ready. So, keep in mind, I could not find a life pack monitor with the little green tracing to match. So if you'll notice, the heart rate of 210 does not match with what looks like a rhythm of 78 beats a minute. So please ignore the actual bumps itself, but please take a look at the numbers. Is this patient ready for intubation or no? Go or no go?
Well, what do you see?
An unstable.
Well, yes, it's the same.
You see unstable SVT, so what does that patient need?
They need electricity first.
Okay, so they need to be cardioverted.
I
Right?
like it. This isn't a trap.
Yeah.
That's a life threat. We need to address that first.
Well, and so absolutely. So 1, we have other priorities. And then 2, if I actually try to intubate this patient in this moment, we proceed with the RSI process, what happens to them? To what?
They could code.
Why? Yes, absolutely, but why?
I could.
Pathophysiology.
I mean, you're changing their. You're sedating them, which
Okay.
ketamine will also
I was about
affect
to say,
everything.
If
And-
we pick the wrong sedation agent, we could do it with our sedation alone. So yeah,
Right.
cool, I'm on board. And then.
You're also
then-
stopping their breathing,
Okay,
and their heart's going 200 plus, and the pressure's already dropped, so they're gonna tank faster than ever.
why? There's one vital sign that will do them in faster than any of the others. Their blood pressure. Why? What's gonna happen when you put that big old hunk of metal or plastic in the back of their throat and lift?
There you go.
You're gonna vagal them, so what's gonna happen to their heart rate?
It's gonna drop.
I mean, it will help, yeah, we'll get their heart rate down, like, so that feels like a win, question mark? But most importantly, it's gonna bring that blood pressure down, and I don't have room to work. If I bring that blood pressure down, you're absolutely right, they code. And by the time, like, we're done with the tube, we're like, oh, cool, that patient with a tube in it.
Now you can start CPR.
Don't the body with a tube in it.
So, you guys gave me the answer to this one well before I asked it, but what are we doing even before the RSI or even instead of the RSI?
Treatment wise, their cardioversion.
Yeah, this patient needs a cardioversion. So chances are, after I cardiovert this patient, well, this will go one of two paths. Either they'll get better to the point where like they don't need the RSI in the first place, or who knows, maybe they still do, but now we have a stable patient, which with whom we are not gonna do more harm ourselves. So yeah, absolutely. Make sure to take care of life threats before we do this like fancy, cool procedure that's potentially dangerous, but a good idea for patients that need it and are stable enough for it. Excellent. Beautiful, beautiful. Let's do this other case right here. I got one go.
Why not?
I got one definite go and one like half-hearted, like, I'm gonna hide it with
Let's
my
do it.
body. I got 3.
Send it. Good.
Vitals could handle it, yes.
This is a go. Now, if you're looking at this patient and being like, dude, they have a SAT of 98, why on earth do they even need an intubation? There's still a hint there. What the heck is that 65?
65.
That's their end title. So this is a patient that like looked terrible until we did the first 2 steps, right? Uh-oh, party foul.
You guys know.
This patient probably looked terrible when we first got there. This patient probably had a SAT that was like in the 50s, 60s, and we clawed our way up to 98 because we did something fantastic for this patient, and now they're stable enough for this. So there's still evidence of that. Their end title is still just absolute trash. But they are ready for this procedure now. So this patient is one that was adequately pre-oxygenated. High fives all around. And this patient's a go. Got you. Okay, how about this patient here?
No.
Saturated.
Why?
They're on the slippery slope already.
Yeah.
Why? What number are you most nervous about? Okay, 62 is a problem. 62 on a SAT is a problem. Now, there's probably somebody in here that's like, but we're about to intubate them, so 62 is like the whole reason we're doing it. Yes, but. What? So, I agree with you. This is a no-go. What are we gonna do before the RSI or instead of the RSI? Cool. So yeah, potentially this is a patient that like, we just weren't quite ready yet. We didn't give that pre-oxygenation time. For some people, that's gonna be a few minutes. They're gonna go from a SAT of pretty good to even better. And it's gonna be plenty. And for other people, it's just gonna take a little bit longer. I'm sure you guys have seen that patient who's like oxygen SAT, you're like watching, just being like, 1, please stop talking. I really need you to go from a SAT of 84 to like 85. And you watch as this SAT just creeps up, literally point by point by point, and it feels epically slow, but they get there. That patient might just take a little bit more time versus maybe this patient's SAT just ain't coming up. We've done everything we can. We went from our nasal cannula to our non-rebreather. Maybe even we tried CPAP on this patient. If they are breathing on their own. Maybe we even tried to BVM them. And 62 is all we got. Now what?
All us.
Do what?
All us.
But you still gotta do something with that. What are
Still
we
got a
doing?
problem.
What are we doing?
Do better gas exchange.
Okay. Yeah.
You can CPAP, I don't know what the complaints are, their mental status, but there's
Poor. The mental status is
Are
poor.
they awake?
more.
Well, then we don't need our size and that stuff.
Okay, to what?
Are they conscious or unconscious?
They still have a gag reflex.
You still have a gag reflex? I don't know. If they do have a gag reflex?
Yeah. They're half in, half out.
So now we're getting to a place where like, we're trying everything we can, we're still coming up empty. Now, admittedly, the patient that you probably can't BVM up is gonna be few and far between, but the point that I'm getting at is like, this patient doesn't need an ET tube. This patient has essentially 0 safe apnea time. And we seem to all be recognizing that, like, nobody wants to give this one a few minutes of not breathing. 30 seconds of not breathing for this guy is probably incredibly catastrophic. Do we have an airway that's more designed for that? So we can
I
get
do.
it faster?
Got a question?
Sure.
I do.
Yeah.
Yeah. Let's
Yeah.
ask if the gag reflex. Could you give just the ketamine? And
Ooh, yeah, so we could potentially do RSI and just pick a different tube. So we'll not do RSI in this more traditional fashion of like, we're gonna go to an ET tube, get this definitive airway. Yeah, we might still give the meds and just put in a blind one.
So,
To get rid of the gag, just to sedate them.
And maybe on this one, all you really need to do is get them sedated, because you don't really need the paralysis with it. That extra tone in their chest is really gonna help you. So this might be a patient that doesn't get the paralysis because you don't need their vocal cords to stop moving, you're not messing with their vocal cords. So they might just need a little bit of sedation to get them to tolerate the eye gel, and then that's it.
Maybe they're anxious, worked up, and kind of their own worst enemy, so just kind of.
No doubt. In fact, that's like where this case is not as straightforward as some of the other ones, because like on that like cardioversion one, it's like, oh yeah, that patient needs a lot of electricity. On this one, it kind of depends on how we got to this point. And I will tell you that most of the time how we get to this point is we just didn't give this one enough patience on the front end. This patient might actually be the perfect patient for the video that you guys saw talked about it, DSI. What did you guys learn about DSI in that video? What is DSI?
the latency.
Okay, I like where we're headed.
Give it more time to oxygenate.
Yeah.
Cause they may come around.
And often with a little bit of sedation. So this is frequently the patient that you CPAP with just a little hint of sedation to get them to just relax and get the oxygen in.
Or +3.
Beautiful. This is that patient who's white knuckling that stretcher. And we just need them to relax a little bit, to slow their breathing down, to take some meaningful breaths so that they can oxygenate themselves. And who knows, maybe once they do that, they'll turn the corner, and by the time you roll into the hospital, you got a patient who's sat in beautifully on a CPAP and you never had to make the transition, versus now that patient's on that CPAP and they're getting sleepier and sleepier and sleepier, and then we now we have a clear path. Now we've got them pre-oxygenated. We'll be talking more about DSIA coming up. Cool. So that was beautifully done. How about this patient number 4 here? I think I heard goes. Anything you're concerned about on this one? you think you're gonna watch?
Maybe a little bit.
Yeah, that blood pressure is a little bit marginal. This might be a good patient to, assuming that we have a choice in the future, pick some medications where I'm gonna do some blood pressure raising rather than blood pressure lowering. Or maybe in our preparation phase, we just decide that like, we wanna get some IV fluids going. That way, by the time, like, in our preparation phase, that's step number 1, we start those IV fluids, so that by the time we get around to the intubation itself, we've gotten a good 10 minutes of fluid in, and maybe we got a better SAT. Not a better SAT, a better blood pressure. A little bit more room to breathe, a little bit more room to work. Is this adequate? Yeah, but it's something that we might turn around a little quicker on, repeat that blood pressure on. That medication manager is just gonna keep a little bit closer eye on, but it's certainly workable. Beautiful, beautiful job, y'all. Okay, so now, it's go time. Patient said yes. Everyone's got the green light all the way around. We're gonna do this. So, medication manager has got their medications all drawn up, and we're gonna do this. Now, the one thing that drives me crazy about this step to make it a P is they've listed it as paralysis and induction, when, please, for the love of God, never do paralysis and then induction. It is always induction and then paralysis. Mr. Richard. I'm pretty sure it's against the Geneva Convention. So we are going to do first induction meds, then the paralysis meds, and then when that patient goes apneic, we're gonna move to intubate. So what I tend to like to do is just take the top of that patient's shirt, whatever, to where I can actually see them breathing. That medication manager is gonna push through your induction med first. You're gonna keep breathing. You're gonna watch it happen. Then they're gonna get a paralysis med. You're gonna keep watching them breathe, and all of a sudden they'll go breathe, breathe, breathe. And that's where we move. But at the point in time that meds are in, we have committed. We're doing the whole thing. We are on the hook for the intubation itself. So now let's talk some meds for a little bit. Okay, induction meds.
Oh, you fixed it.
Yeah, I felt bad. Like immediately I fixed it. So in a perfect world, well, let's talk about meds that we already have currently. So meds that we already have currently, ketamine and Versed. Those were the ones that were on the slide originally, but bad news. All of the ketamine that we own currently is out on the trucks at this moment. There's no more ketamine. Their chances are not gonna be any more ketamine for the rest of this year. So the only time that we probably anticipate getting more ketamine is in January. And if you, I'm looking around, and some of this is known by some of you, and some of you guys are like, oh, well, I don't feel like getting punched in the face. True, we have a solution for that. So with the ketamine, it probably will not be an option for the first little bit that we do RSI. So that's why we are probably moving to add etomidate as an option. Admittedly, etomidate and the midazolam work fairly similarly on slightly different timelines, but they do work similarly. Both of these are going to do induction. Both of them are going to do a little bit of blood pressure lowering. So it does make the procedure a little bit harder. We may have to do a little bit more prep on the front end because we're not going to get that help from our medication, but can absolutely be done. What else do I need to say about induction agents? I don't feel like I said enough.
It's good.
It's mostly bad news of telling you there's no more ketamine. Oh, the other thing that I wanted to say about induction agents, and I appreciate that you brought up the sedation scale. So on anyone that we are going to do the whole sedation scale on, potentially we are taking somebody who is a -5 on the RASS scale already and proceeding with intubation. And so we need to do an appropriate amount of induction agent for every single person on that scale. So some people are gonna get more, some people are gonna get less. It is tempting to say that some people are gonna get 0. And I would caution you to that. Even the person that is already completely and totally out of it, just give them a little touch of sedation. Cause the time that you wanna find out that they weren't sedated quite enough is at the point in time that you put a laryngoscope in the back of their throat. That's a bad time to find out new information.
Did you?
So, even if we're doing a low dose, let's take midazolam for example, because it's one that you guys are more familiar with. The patient who is on the positive side of the scale may need something closer to like a 10 milligrams. The person who is on the like -5 end of the scale, maybe they get 2. It's not a lot, but it's a little extra just in case. I really don't want to find out the true depths of somebody's gag reflex at the moment that I really need things to work. So err on the side of a little bit more induction than a little bit less induction. And on that same vein, paralysis is very much on this vein. Paralysis is like a light switch. You can't be kind of paralyzed.
Turn it off, turn it off.
You can either be paralyzed or you're not. And so legitimately do or do not, there is no try. If we're going to give a dose of paralytic, I would rather you aim a little on the higher side than a little on the lower side. It will probably come out in the guidelines, it'll be a recommendation of 1.2, but.
They have 1.5 in it right now.
Well, I got another email this morning, but,
Oh.
you know, who knows? What you should hear from me is I am very supportive of you rounding in this moment, and particularly with paralytics, round up. The bad effect of the paralytic, if you give too much, I'm not saying give every vial to every, like the whole vial to every patient, that's not what I'm saying here, but give a little bit more than a little bit less. The bad effect of giving a little bit too much is that they are paralyzed for longer. Okay. We were already on the hook for their airway. You're going to breathe for them. So whether you are on the hook fully for their airway for 30 minutes as opposed to 45, yeah. Still happening.
Turn it off.
So round up. Get yourself a nice easy number. If your calculation of 1.2 or 1.5 is coming out to 96, cool, that sounds like 100 to me. Okay, now we got meds in. We have done our full prep. What's our next step? Oh, to here? Yes, we have done our preparation at the very beginning. Then, second step,
Ready to administer.
Pre-oxygenation.
pre-oxygenation. Then we did what? I heard something that definitely started with P and I couldn't understand it. What's our third step? Our pre-procedure timeout, I like it. And then, paralysis with induction, and then, I was about to say, this one's kind of a sleeper. This one's kind of a sleeper in the middle of it. It's gonna be positioning. And so what I mean by that, if you're thinking to yourself like, hey, no, I'm a fantastic pre-hospital provider, and I was doing positioning from the get-go. Yes, you were. But now we're moving into the patient into positioning for the tube itself. So keep in mind, like, this might be a patient who's breathing spontaneously on their own and working at it. So you might have them in a full Fowler's position when you first see them. They are working hard. Do not take that away from them. Give them every respiratory advantage that they have. What I mean by this is that patient that you have now given them meds, and now they're not breathing, so they don't need every respiratory advantage on their own. We need the advantage to actually place the tube. So now we're moving into a position that is suitable for the intubation itself. That's when we're gonna go to that ear to sternal notch position. You can see on that patient, their ear is aligned with their sternal notch, it's nice and flat. And so it may be the patient who goes from full Fowler's to 45 degrees, but we're just moving them into that position. Cool? Do not skip on the step will save you. If you guys haven't heard enough about positioning from me, I will set a personal session if I'm talking to you about airway positioning, but I'm guessing that's no one. So, okay, Now for positioning, somebody already told me what the next step is, and it is, what? Placement. ET2 placement with proof, so, do the thing. And yes, this image had a word that I covered up there. So will the next one. So, now, this is also another little sleeper step because there are 2 steps in this step. You not only gotta place the ET tube, but you gotta prove that you did. So, do the thing, and you better be really sure. And title CO2. So, our fantastic EMT partner is just hooked up the end-tidal CO2 immediately after the tube is situated and secured and blah, 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 blah. And we're looking for a waveform capnography because that is our best bet. What happens if you don't have it?
You're not,
Say what?
you're not in the lumps. There's
Okay.
no gas exchange.
So what do you do?
Yeah. And then?
You confirm the placement.
Do you leave it or do you take
Oh,
it
you
out?
gotta take it out.
And really, that tube comes out immediately. If you don't have that waveform capnography, this is the only one of the like many things that you can check to check where a tube is that doesn't get faked out. So what are some other things that we can check to make sure the tube's in the right place?
Condensation.
Condensation.
Chest
Lung
rise
sounds?
and fall.
Do what?
Chest rise.
Okay.
Direct visual.
Uh-huh.
Comply with this.
Okay, so these are some fantastic ones. So, I'm hearing that the person who actually placed the tube watched the tube go through the cords. Absolutely, that is helpful. But how can that fail you?
Can't prove it.
Once we get you video, I'm hoping that you can prove
Oh,
it,
there
but how else can it fail you?
If it moves slightly once
Okay.
you pass it through the cord.
Yeah, tubes can move. The other thing is, this one's a bit more tricky, the esophagus, and some people can have what's called false vocal cords. It doesn't really look like vocal cords, like if you know what you're looking at, you're not gonna get tricked, but there are some kind of like little flappy things, and so just having seen the tube go through the cords is not foolproof. You gotta actually be able to have the waveform after the fact because you're right, the tube could have moved. So, seeing the tube go through the cords is not fail-proof. What else? Somebody said breath sounds, and breath sounds bilaterally.
And negative epigastric.
Okay, foolproof. Yes or no? I'm hearing like a, yes, I want it to be true, but
No, it's
and it's not.
It's not. It's not.
It's not because if you get that tube in the, the hypopharynx, to where it's not truly in the trachea, you'll get breath sounds. There will be some air that's making it into the lungs to give you breath sounds. It's also super easy to, I don't wanna say fake at that time, but like, you're listening over the bag of making all that noise. So it's easy to get faked out. And then absence of sounds over the epigastrium. Well, what happens if their stomach was empty? Their stomach is only gonna make noises if there's air bubbling through what's already in there. So you gotta write that there. Fogging is, I mean, honestly, you can put it, no, we're gonna choose not to say that out loud. Almost every place in the human body is capable of creating fogging. There we go, that's a safer way to say it. Every place in the human body is going to be
It's
warm
for tube
enough
placement.
and of enough humidity to cause fogging. There we go. So yeah, that one's just not fail-proof. Now, the thing that is fail-proof is to get that true waveform capnography for 3 distinct breaths. So tube goes in, you get that 1, 2, 3. Chances are you guys have seen the hospital intubate with an end-tidal CO2 colorimetric detector. Mini seizure every time the hospital makes me use one. And if we, like, I mean, pre-end tidal CO2 capnography, like, that was the gold standard. Now, not so much. Why? How can that one get faked out? How does it work?
Reads CO2,
Okay, read CO2. Beautiful.
changes color when
Uh-huh.
it detects CO2.
So if you hold that bad boy over a freshly opened can of Coke, it'll change color.
Sweet.
And so now you can imagine a patient who's had a big gulp 30 seconds before they like choked on the hot dog. Now we need to intubate them. They got a stomach full of that beer or that fresh Coke. You put colorimetric over that stomach, you're gonna get gas exchange. It's gonna look like there's CO2 there. It just happens to be in the wrong spot. So that one can get faked out. Nothing, and I mean nothing gets you the confirmation like waveform capnography. It is the end all be all. Cool. So yes, if you get no exchange on your waveform capnography, that tube comes out. Without fail, if you leave that tube in, confident on all the other rest of the things, that patient is going to roll into the ER, very brain dead, and with a ton of air in their stomach. So please, don't let your pride win this day. If you don't see it, that's fine. Pull it out. Get it in a NIGO. Get the patient to the hospital alive. Besides, part of our plan was to have backup methods in our preparation. So, we planned for this. So, now we have waveform capnography, and we get to keep this tube in place. We are a go. Now we only have one step left. Do it?
Secure? Reevaluate, reassess?
Reassess for what? What? You're headed in a good direction.
Sedation.
Consciousness.
And specifically the consciousness, because keep in mind, we have now given them specifically a paralytic that's gonna last quite some time. And sedation agents that won't. So remember, they may not wake up like we're expecting them to. So we have to move immediately from this into our post-intubation management phase. Once we get the tube, once we secure it, once we confirm that it's in place, our next step, and it is so integral to the process that it is in the process. This is not something we do after we intubate. This is part of the intubation process, is to get these meds on board. So ketamine's probably not gonna be an option, but it was a great one because it did both sedation and pain control. So chances are we will have to pick a combo. The chances are we will have to pick a combo, so that'll be fentanyl with a sedation agent usually, and we'll just have to do them in combination and just immediately following the intubation, so that that patient isn't in there awake and paralyzed.
How long does the time left?
About 5 minutes, 5 to 10. So that actually is a fantastic lead-in into talking about the RSI timeline. Because so much of this is about time and optimizing time and safe apnea, and so a lot of it is about time. So if we take those 7 Ps, this is the times that are associated with them. Now, we do have to update this to make them, one, less archaic, and our 7 Ps. So, we're gonna take out that pre-treatment, we're gonna take out the fact that this chart, for some reason, said rapid sequence intubation instead of rapid sequence induction, and change the timing on that one. So, that pre-treatment becomes that pre-procedure timeout. So we still got the same steps. We got our preparation, we got our pre-oxygenation, our pre-procedure timeout, our paralysis with induction. Why does this one say protection? I'm guessing that means securing the tube. Nope. Protection is apparently positioning. I need to fix that one too.
Tomorrow's another day.
Tomorrow is another day. Protection is positioning, sorry about that. Then we do the placement with proof, and then we move into our post-intubation management. And so what we noticed on the timeline is those first 3 steps happen slowly. We got time on our side. You guys have seen that patient who just takes a long time to get their sets up. And so we don't need to move into this very quickly. We need to make sure that the patient is stable enough for this finesse thing that we're about to do. And so we can take our time on this, on the front end. And so if we show up with a rescue, just a rescue, and all of a sudden we're like, oh, this isn't what we thought it was, and we need more people, we got time. I already got 2 people that can start the process of preparation and pre-oxygenation while we've called for backup. While we've called for a 3rd or 4th or 5th, or maybe we don't need more people than 6, but we can call for more people. And we still got the preparation, and that pre-oxygenation takes at least a couple of minutes, even when that patient is oxygenating well, because we want that washout, we want that CO2 washout, so it's gonna take a few minutes anyway. Can't rush through it. So we're gonna move through these phases slowly, so somebody has time to come there. So let's say that we only have 1 paramedic and 1 EMT on scene. Cool, easy breezy. I got that EMT who is getting all that equipment set up. They have started to pre-oxygenate that patient. The medic is picking the meds, drawing them up. They'll be ready to go by the time that person shows up. That 3rd person can either move into the airway role, or, come on, let's be honest, they're gonna move into that medication manager
Yeah,
role.
let's be real.
It would really help the other cure vets.
She hates them.
I don't hate them for, well, I hate them for what we were using them for. There are better options. Is it still probably a better option than nothing? Maybe. Say what? Yeah, I mean, maybe. And maybe that's what we do, is the patient who gets intubated gets care vented for the time being while we can get something.
Oh, we don't have care vents
Oh,
anymore.
then never mind.
We have EMTs.
And you know what? It works. I can tell you that I worked for a hospital in Kenya for a while, and they simply didn't have vents. And so if we were gonna go intubate somebody, it was like a conversation with that patient, that patient's family of like, hey, look, you're gonna need to line up enough people to like keep this train rolling. You better hope that Uncle Bobby doesn't fall asleep on his night shift. Somebody's gotta keep bagging. So, it can be done. Okay, so yeah, moving slow on that first half of things allows us to move quickly in that second half of things, and stacks the deck so that we are able to move through those steps quickly. So once we actually do the induction with paralysis, things move quickly. Moving that patient into position, it says 30 seconds after induction. It's really more about allowing the medications time to work, so that patient gets moved from that whatever respiratory position they were in before into that most optimal intubating position. That tube happens fairly quickly too. When it goes well, it goes very well. When it goes less than ideal, we still got a little bit of time on our side. We're still talking in the neighborhood of a minute, 2 maybe. And then moving into that post-intubation management immediately afterwards. And so we do the first piece of this deliberately slow, so that we can move through those next steps quickly. And I'm sure you guys have seen this before. Slow is smooth, smooth is fast. That's how we move through this process. And so what questions can I answer for y'all? Yes?
Will we see any type of like, circulation or anything like that?
With rock,
After
no.
rocking?
So rock is a non-depolarizing one, so rock will have 0 fasciculations. Now, admittedly, with how sick a lot of the patients are that we see, even with a depolarizing agent, a lot of times you won't see those fasciculations. The times that I would frequently see fasciculations, they'd be in trauma patients. That person who was like normal, healthy up until 15 minutes ago, and then all of a sudden something really catastrophically bad happened. That person is still gonna have enough reserve to have fasciculations. And honestly, they may have some pretty pronounced ones, as opposed to like the person that's been clinging to life for 3 or 4 days now, and you guys find them just barely on this side of the grave. That person is probably not gonna fasciculate, because they just don't even have like the electrochemicals to do so. But rock will be non-depolarizing, so you won't see a thing. They'll just stop breathing.
I've never seen
Say what?
45 minutes.
It depends on how much you give, but usually about like 30 to an hour. So the post-intubation management, kind of important. I mean, the intent is to make it so much muscle memory that it just becomes the next step. Just like we put in the tube, we rip out the stylet, we like, all those things become such ingrained muscle memory that they are just part of the process. Yeah, same thing with post-intubation management. Second we get it hooked up, we got our placement with proof. Somebody's hooking up all the patient to the monitor, doing vitals, and our medication manager has those drugs ready to go, and they're just going in next. It's just a part of the process. Any other questions? That can't be it.
Clinching, it should take care of any clinching, yes?
Yes.
For the trauma patients?
The paralysis, yeah. And if you find that it hasn't taken care of their clenching, then one of two things has happened.
You need all those ropes?
Um, One, we were trying and not doing, so they need more drugs, or they have rigors.
In that case,
That's not.
You think I'm kidding? I can't tell you how many times I've been told, like, we just gave them a ton of paralytics and their jaw was still clenched, and I was like, yeah, well, they're dead. It can happen for days, so, not days. Can't overcome rigor. Any other questions?
Who made your PowerPoint?
Say what?
Who made your PowerPoint?
Me?
Great.
Oh, fantastic PowerPoint. That's what I was gonna say.
Now that I'm self-conscious about it, what do you want me to fix? What do you want me to fix? What's wrong?
That was beautiful.
Okay, nobody believes that anymore, but thank you.
So why do we not like the vents? I'm only asking because for us, you know, hands-free, it helps. Maybe.
I have nothing against hands-free. The problem is that it doesn't do what we expect that it does.
Is that just specific to the care vent?
Correct.
Okay, so.
Yeah. I have no
There's
problem with
something
that.
else out
We,
there.
honestly, we just need something more sophisticated. And what I mean by that is the care vent is just too simple a device. And let's call it what it is. Ventilating somebody is just not simple. It's just not as simple as like turning it on and like going. Like, we have to be able to pick a whole lot more about the ventilation parameters. Now, are we capable of doing that? Yeah, heck yeah, absolutely. We just need a device that allows us to do so. It doesn't have to be like one of these hospital behemoths that like we can like prone people on and like crazy stuff like, no, none of that. But, and I'm sure you guys have seen the vent that Lee County has. Not a huge fan of that one either. But there are sophisticated ones that are small, and Air Methods loves theirs. The Revell, super expensive, but they love that one. There are plenty of vents that just aren't the simplicity of the care vent.
So Lee County's is good, the one they use, or no?
She's almost through it.
I wouldn't pick it myself.
But they're like 35 grand, right?
Oh, God.
So was they?
Yeah, they're like 35 grand. So we're not,
It's a lot of work to get it set up.
you got an EMT, you're not paying that.
Cost of one plate, at least one.
Hire one more EMT. That's what we're paying.
It's not the vent I would have picked.
Pay back after one trip.
There's a lot of idiosyncrasies about it that are just,
So we are working on the camera, Orangesco.
Oh, yeah.
That's coming.
Yeah, October, it's in the new budget.
and I was gonna say, don't hold me to this as a promise, but we have technical,
I'm not
like, we
sure.
have
She knows.
supposedly laid out a timeline of like what
We should
in-services
get a,
come next. And we're
practice.
hoping to have some demos to you guys in September to allow you guys to play around with it. That way, when new budget comes around, October, November, we can actually have the devices to get them out to y'all. So it'll also allow you guys to practice with the whole process and all of that. So we're planning to do the checkoffs obviously before we get VL devices, so that we can essentially do this process with whatever equipment we choose to. We can do this with DL like we have currently. Just like when we had VL, we can switch over into that, but it'll allow us to practice with both of them. So yeah, this calendar year?
And ketamine, just, I hadn't heard that it's a national shortage or?
Oh, yeah, can't get it anywhere.
Can't get it anywhere.
So you said it's 5 minutes, so
Once we have the tube, we're giving percent fentanyl.
Yeah, that was the one thing I was gonna ask you to cover real quick, cause you
Yeah.
showed the drugs,
Uh-huh,
and,
times.
yeah, we didn't just spend enough time talking about the drugs.
Okay, so okay, for induction agents, all of these are fairly short-lived. So your etomidate is probably your shortest lived of them all. This has been historically a medication that has been used for intubation regularly because it gives you literally enough time to get the tube, get it secured, start more meds.
And we should do like Dipperman and stuff.
Yeah,
Yeah, with the etomidate, you can't really mess around, like, by the time you get the tube in, you got it secured, you really need more meds on board, because they will start to wake up. Ketamine, you guys are a bit more familiar with, a bit longer lasting. Certainly for intubation, we're not doing, we'll have an IV. We're certainly not doing RSI with IM doses. So we are probably looking in the neighborhood of, ketamine is probably gonna be, I don't know what they have in the guideline currently of, I wanna say it's 1.5 per kg of ketamine.
Sounds good.
No?
I thought it was still one.
For the intubation itself though? I don't know. It'll be somewhere between the neighborhood of 1 and 2, per kg IV of ketamine. And it's also decently short-lived. You might get like a good 15 minutes out of the true deepest sedation out of it. And then same with the midazolam. Now, will that patient be sedate for will they be sleepy for quite some time? Yes, but not like sleepy to the point where they can tolerate an ET tube. So the amount of deep sedation that you're gonna get out of NMDs is fairly short-lived. So we're talking like 5 to 10 minutes for the etomidate, maybe 15, 20 for the ketamine, 15 to 20 for the midazolam as well. So all fairly short-lived. Your rock is gonna last 30 minutes to an hour. Probably closer in the neighborhood of 30 to 45, but notice, definitely longer than your other meds. So you're gonna need to do your induction, your paralysis, get your tube, and then move to more meds. And then more meds. Now, in our post-intubation management phase, Versed fentanyl is probably a safe combo. It is probably the one that causes you guys the least headaches. Because remember, we're not looking for that same deep level of sedation. Well, I say it's the one that causes you the least headaches, assuming that we don't have ketamine. Because chances are you might be able to dose these once and get all the way to the hospital. as opposed to etomidate, which you may have to dose and redose and redose. So that fentanyl Versed combo is probably gonna get you a little bit more time. But keep that in mind, like, there is a decent chance that you will have to redose these on the way to the hospital. Do what?
Depends on how fast you drive.
It may not have anything to do with driving, cause keep in mind, you just got them intubated, you're still gonna have to pack up all your stuff. You still gotta get them all settled, like, you may be able to drive fast, but like, might just be a little bit. It's okay. I'd rather get the patient there safely and well managed than gagging on the tube as you roll in the door. Probably not good. What else?
Oh, that was good.
I have a question.
Yeah.
Are these medications going on both the engine and the rescue?
Oh, that's, we'll have to decide.
It's a great question, I'm glad you asked.
Yeah, it was just cause, did you want this typical procedure to be back on the rescue with wheels getting ready to go? Or is this something we could do on scene, not the best sterile environment?
Honestly, I'll trust your judgment there. Do I think that this is easier to do in the back of an ambulance? Yes. However, you guys know your scenes, you guys know that every single one of them is different. Sometimes this is just better done on scene.
I know we don't transport the engine, so we don't need a lot of the post innovation stuff.
So,
Back up to the bed.
I trust you guys
So
to
back
to
up.
figure that out.
Yeah.
Now, where I would recommend that the one setting that I recommend that we don't do this in is with wheels rolling. If we're needing to do this, this is a
Catch before we leave.
catch before we leave
Pull
or
over.
pull to the side of the road.
He was gonna say, cause if we did that on the bus, at least if the patient's all packaged and on the stretcher, strapped in, then once you give your post innovation meds, we can roll out. Instead of now we're getting them on the stretcher, we're worried about misplacing the tube, all these things.
Yeah, the ones that are clenched down on the side of the road,
That was our big time.
yeah,
back in the day.
used it mostly for that.
And so like, yeah, I trust your guys' judgment on this. This might be on scene, this might be in the back of the bus. Now, I will say, if you do it in the back of the bus, don't be tempted to immediately after I push drugs to like get on the road. Make sure that that patient gets settled, make sure that like we have everything in place. Watch their vitals for like a minute or two before we get wheels rolling, because remember, all of this stuff, when we were picking patients to go through this procedure with, this can be very destabilizing for a patient. And you certainly don't wanna get like that second or third blood pressure and all of a sudden like, and now you got one person, two people in the back with like a crashing patient, when it could have been something that like, if we just take 2 more minutes on scene to make sure that they're stable, make sure that everything's good to go, that we could have avoided. I have learned this lesson by taking a patient to CT immediately after intubation a few times. And now I don't make that mistake anymore.
Let's go practice.
You live, you learn. What other questions can I answer? These are fantastic questions, y'all.
To move away from Dippervan, is to stop, to get away from that.
She doesn't like it.
She don't like it, cause that's what we had before, but there was cases that was a runaway Dippervan trip, and they were just snowing patients for.
2 or 3 bottles worth.
Well, you know, on the report only said 1.
Yeah.
But you use a 10-drop set instead of a 60-drop set, and it's,
Yeah.
oh, bye-bye.
And bottles,
I mean,
yeah.
Yeah.
Is there anything wrong with propofol itself? No. I honestly, my qualms come from propofol from the ICU standpoint, and the ICUs here love it for God knows what reason, because it does create a whole lot more ICU delirium and more prolonged sedation. But
Does it majorly affect blood pressure?
a lot. More than any of these. A lot. We got tons of good options. And one of the things that I would love to be able to, get you guys in a meaningful way is IV pumps. So that like, not only can we take the medications that we have, but use them in different ways. So, that is a more long-term thing. But, and I mean, I have the same philosophy about my own first aid kit that I travel with, is like, my own first aid kit that I travel with is a teeny tiny little thing, but nothing gets in there unless it does double duty. So, I mean, this is where ketamine like really caught fire in EMS, is because I can do so many things with this one med. I just have to use it in different ways in different scenarios. It's admittedly why etomidate is probably not one of my favorites, because like we're not using etomidate for seizures.
Speaking of seizures, paralytics and seizure patients.
No.
Moment to stop. Moment to stop.
They're still having the seizure.
And the reason I say no and so wholeheartedly is because you can get what's called non-compulsive status. So like you may not see them moving anymore,
Right.
but they're still seizing. I was about to say, you can get this even without giving patients paralytics. I'm sure you guys have seen this, like this is the seizure patient, but like every once in a while, you just still watch them twitch a little bit. You're like, maybe they're post-ictal, but once we hook them up to an EEG machine, they're just still seizing. Can be very dangerous. That was a great question. Non-compulsive status is a. You guys have fantastic questions. I'm having a great time. Anything else, Al?
Professor, any other questions?
No, we can let
Hey, you got some room.
I do, but.
This
Wait for you.
spot,
I want to embarrass myself.
You're turning over, I can see from back there.
Smoke coming out of my ears.
That's normal though.
For credentialed EMTs at the county, do you need, IVs?
They are.
And can we? You're saying that with
Under-
the
under-
EMT,
how's her-
healthcare.
I'll admit, I have mixed feelings on this. The state of Florida has always gone a very different route than the rest of the entire country. So, these are not my words. These are, this is coming from the National EMS like scope of practice document. They specifically note that EMTs don't get IVs in that national scope of practice document, which has always like been in contradiction to what the common practice is in Florida. And I'll leave that there.
Don't get IVs, meaning they're missing them?
They're not allowed
Not allowed.
to
Yeah.
obtain IVs.
Because it's like an EMT, intermediate.
Correct.
Yeah.
So how does, we're all
All they need to do is plasma.
Oh, so yeah, Florida is a delegated practice state, so remember when we were talking about how like, the beauty of airway is like, we can do whatever we wanna do? Yeah, theoretically, if, like, we could come up with whatever weird ass procedure we wanted to, and the state of Florida says it's cool as long as I'm down with it. It's, most of the time it's used for good. But admittedly, Florida's a bit like the Wild Wild West. You can be as good as you want to be or as bad as you want to be.
They go through, what type of additional class do they have to take before they're allowed to?
For the IV,
Yeah.
it's their own homegrown thing.
Cause I know we talked about doing it here at one point, but.
I know FSW is starting to put on a class for starting IVs and drawing blood and
I mean,
all that.
like at the hospital, they just put you through like a 2-day, 8-hour phlebotomy.
Phlebotomy class.
Assessing the risk and all that stuff. I know how the hospitals.
Yeah, I mean, I'll be honest, I do not know why that has been in the, like, it is so specific in the National Scope of Practice document that like, it clearly was a point of, I don't know how it got there, but it did get there. EMS is so different state to state.
I mean, it Just sometimes you have 2 medics on the scene, but if you have 5 people and everyone's certified, it does alleviate some, stuff, I feel like, sometimes.
We usually don't have issues getting anybody.
No, I know, but it is.
I was about
if
to
it's
say, we're
allowed,
not
it's
turning
just-
the paramedics, so.
Just pre-oxygenate, go get there real quick.
You need to drive your You're ready.
Right, you're.
You can start it yourself.
So anyone else who doesn't have any questions, we duck out, but I'll hang out for a minute if you still do have questions.
Mario will be sticking around.